Okay. Yeah. Can we see my screen?
Yes.
Okay. So we should check the question I posted on our page. So somebody just sent me that, and we can just attempt. Yeah. So moving on to pneumonia. So pneumonia is just like we know, like it's infection or parenchyma of the lung. It could be from bacterial, from viral, or even fungal infection. So it's very, very common in people that live in probably like, overcrowded situations, people that smoke, take alcohol, or people that are immunocompromised, or people with some comorbidities like COPD. They can have pneumonia easily. And how would they present? Fever, productive cough. So for the typical causes of pneumonia, we expect fever, productive cough, difficulty in breathing, pruritic chest pain, But for the atypical cause, we might see like dry cough. So if we see somebody having dry cough, and we're thinking pneumonia from the fever, the dyspnea, the pruritic chest pain. So we should think about the atypical causes of pneumonia in that kind of person because of the non-productive cough. So that pneumonia is going to be coming from things like Legionella, Mycoplasma, and Chlamydia. As simple as that stuff is, it can save us a lot of headache just by looking at the cough. Is it productive or not? So if the person is having other constitutional symptoms like malaria, think about something else. It could be from, you know, influenza. If the person is having like sore throat, think about something else. You know, um, it could be like group A strep if it's sore throat. If you are seeing GI symptoms, it could be Legionella. Legionella GI symptoms. So if we do our lung examination, what are we going to see? There's going to be decreased, or bronchial breath sounds. Breath sounds usually decreased. You can have bronchial breath sounds. We are going to see the like peak derails, wheezing, dullness to percussion. They can have egophony and increase theta parameters because of the consolidation. So theta parameters is increased. So how do you make diagnosis of pneumonia? We just do a chest X-ray. That's what we do. You can do initial imaging, which is chest X-ray, and we're going to spin the patchy opacities. Depending on the type. So if it's lobar pneumonia, you are going to see like opacity confined to like a lobe of the lung. We can have bronchial pneumonia, we can have lobar pneumonia, we can have even like interstitial like pneumonia. So most of the cause of interstitial pneumonia are all these atypical organisms like Legionella, Mycoplasma, Chlamydia, pneumonia. So one thing I just want to mention is that once you are seeing feature of pneumonia and the person is having GI symptoms, think about Legionella. If the person is having a rash with pneumonia, erythema nodosum, erythema multimiforme, the person is a young child, and is having like a rash with pneumonia, think about um, Mycoplasma pneumonia. Very, very important. So, so X-ray is the best initial test to do. We should not really worry about this. What I just want us to just have in mind is that most of the cases they are going to be giving us is going to be like community acquired pneumonia. And, we should use a COP65 scoring system to stratify how we are going to treat that patient. If you are going to admit to the ICU, we are going to just hospitalize normally, or you are just going to treat outpatient. So, the component of the COP65 is the C standing for confusion. So any feature of confusion, what's the urea? Is it more than 7 or more than 20 millimeter of mercury? More than 20 milligram per dl. What's the respiratory rate? More than 30. What's the blood pressure? Is it less than 90, 60, and what's the age? 65. So COP 65, COP 65. So any score of 0 to 1, you can manage outpatient. Score of 2, hospitalize. Score of 3, consider for ICU. It's just as simple as that. 0 to 1, outpatient. 2, hospitalize. 3, admit to the ICU. So we can also do like a gram staining of like the culture, gram staining of the sputum rather, and we can see the picture here. So if you look at this now, this is looking like a gram positive cocci in clusters. So this is likely to be staph. You can see the clustering, and we can see that it's purplish in color. So this is likely to be a gram positive cocci, which is staph. Now, if you look at these two, the organism is blue and it's kind of paired. They're kind of, appeared in like paired. So this is likely to be gram positive diplococci, which is for strep pneumo. The atypical organisms, they don't grow on standard culture. So you have to have a very high clinical suspicion because they don't grow on standard culture like Legionella and Mycoplasma. Yeah, even viruses too. Influenza, like we have here, parainfluenza, COVID, and the likes. So this is just a category of the bacteria. The typical ones: strep pneumo, H. influenza, Moraxella catarrhalis, Staph aureus, group A strep. They are the typical causes of pneumonia. Sore throat, group A strep. Strep pneumo, H. influenza. These are typical causes. For the atypical, you are seeing like Legionella, Mycoplasma, chlamydia, for the viruses, influenza, COVID. So there are some risk factors. I don't really expect us to be cramming all these risk factors because to me it's not actually necessary. But just to know it. Alcohol use, think about CLEB and anaerobes. CLEB and anaerobes. Those are the two important ones for alcohol. People that aspirate, think about the group A, strep, think about Staph aureus, think about anaerobes and the enteric gram negative. So strep, pneumo, Staph aureus, and the anaerobes for aspiration. COPD, just think about most of the typical causes. They are in COPD. Exposure to animals, so birds, they can have avian influenza. Birds too can, spread chlamydia psittaci. So people that interact with a lot of birds, they can have chlamydia psittaci. They can have the avian influenza. They can even get exposed to histoplasma capsulatum. Animals like bats especially. So when they explore the caves where those bats stay, they can develop histoplasma there. Coxella bonnetti too, especially where they slaughter all those farm animals, they can develop Coxella bonnetti. This one will affect the liver too, can affect the liver. HIV, think about strep pneumo. Immunocompromised people, think about strep pneumo, think about tuberculosis, think about pneumocystic jirovecii. Pneumocystic jirovecii, Mycobacterium tuberculosis, strep pneumo, and histoplasmosis too. It's very common in people that are immunosuppressed. And even aspergillosis. So aspergillosis, histoplasmosis, pneumocystic jirovecii, TB, and strep pneumo. Strep pneumo, TB, and the fungi. People that have traveled, maybe they went for, a boat cruise, hotel, Legionella, and they're not having diarrhea, neurologic symptoms and diarrhea. Legionella. Structural lung disease, think about Pseudomonas and Staph aureus, depending on the age. Adolescents, Pseudomonas, young child, Staph aureus. So, yeah, that's that. So, okay, somebody has a question.
Yeah. Dr. Lucas, can I see the options for the aspiration, the organisms for the aspiration that you mentioned, please?
Yes, strep pneumo, Staph aureus, the mixed anaerobes. Strep pneumo, Staph aureus.
Thank
Can
you.
get them in there. You're welcome. So, for people that are compromised and they have structural lung disease like bronchitis and cystic fibrosis, you must always give cover for Pseudomonas. Give cover for Pseudomonas when there's structural lung disease. Very, very important. And what you want to consider is usually piperacillin tazobactam. So you can add another respiratory fluoroquinolone, or you can add a respiratory fluoroquinolone or a immaculate to that, especially if you are now placing this kind of person on a mechanical ventilator. So person has a structural disease, structural lung disease like cystic fibrosis, automatically you must get one anti-pseudomonal antibiotic like piperacillin tazobactam. If you are now placing on mechanical ventilator, you need to add another one, which would be, a respiratory fluoroquinolone or immaculate. Now, how do you treat somebody that has pneumonia? So you just want to use the COB 65, to first stratify. Am I going to hospitalize this person? Am I going to take the person to the ICU? Or am I going to manage outpatient? So if you are managing the person outpatient, and the person is like less than 65 years, no comorbidity, no chronic infection, nothing like diabetes, CKD, CLD, nothing like that. Just give your macrolide, your amoxicillin or doxycycline, AMD, amoxicillin, macrolide, or doxycycline. But if the person is more than 65 years, or the person has any comorbidity, diabetes, liver disease, renal failure, any of those, so just give your amoxiclav, or so either you are picking amoxiclav only, or you are using a cephalosporin with a macrolide. A cephalosporin with a macrolide, maybe ceftriaxone and azithromycin. That could be what you are going to see in the exam. So amoxiclav or cephalosporin plus macrolide, you are okay. So sometimes they can also, they can also use like a single monotherapy of a respiratory fluoroquinolone. But always remember this combination, cephalosporin plus macrolide. If this person is having community acquired and you need to hospitalize, you can use the same thing, your cephalosporin plus your macrolide, or a single monotherapy with a fluoroquinolone, just like what you are doing in people that are more than 65 or anybody with a chronic condition. Either you are using your cephalosporin with your macrolide, or you are giving fluoroquinolone monotherapy. The same thing is what you do if the person is requiring hospitalization. Fluoroquinolone or cephalosporin with macrolide. If the person is now being taken to the ICU, so you need to now combine your cephalosporin with a macrolide, or you use your cephalosporin with a fluoroquinolone. So you don't give them fluoroquinolone monotherapy if you are taking them to the ICU, because the organism vary, but we cannot be learning all these organisms. It's a lot. If the person is hospitalized, we have said it, the person either use fluoroquinolone monotherapy or cephalosporin with macrolide. But you need to introduce anti-pseudomonas agent to that person. So start anti-pseudomonas agent if the person is having a structural lung disease. So you can give piperazine tazobactam. If the person is not critically ill, that is, the person is in shock or requires ventilatory support, you have to add another one, like maybe a respiratory fluoroquinolone. So you have to use 2 with an anti-MRSA agent in the hospital. So you hospitalize, you give piperazine tazobactam, fluoroquinolone, and vancomycin to cover for MRSA. If you are, taking somebody to the ICU, you are ventilating, or the person is in shock. Because the person is having a structural lung disease, the person is taking piperazine tazobactam. Now you are ventilating the person, or the person is in shock, you add another one again. Then you also give an anti-MRSA agent. So that is that about the algorithm. Just always remember, if the person is normal, just give AMD, amoxicillin, macrolide, or doxy. If the person is more than 65 or having any chronic illness, it is the same thing as person requiring hospitalization. Cephalosporin plus macrolide or fluocinolone monotherapy. You are taken to the ICU, cephalosporin plus macrolide or cephalosporin plus fluocinolone. But if somebody's being hospitalized and the person's having like structural lung disease, you have to manage for pneumonia, for pseudomonas. So piperazine taxol plus another anti-pseudomonas agent plus cover for your MRSA, especially if the person is critically ill and is needing ventilatory support. Anti-pseudomonas, sorry, I said pseudomonas, anti-pneumococcal agent should be given, like in terms of vaccine, anti-pneumococcal protection should be given in form of vaccination to anybody that is more than 65 years. So once you are more than 65 years, you need to take pneumococcal vaccine, or to all children too, especially if they are less than 5 years. So they need to take, coccal, vaccine. Another indication for pneumococcal vaccine is anybody with any chronic problem, CLD, CKD, diabetes, smoking, asplenia, immunodeficiencies, CSF leaks, cochlear implant, they all need to get Pseudomonas pneumococcal vaccine. Why am I saying this? Pseudomonas, okay. Pneumococcal vaccine. So don't forget about that. Anybody with any chronic problems, smoker, asplenic patients, people with immunodeficiencies, CSF leaks, cochlear implant, give them pneumococcal vaccine. So let me see if I have any question here. Why pneumonia? Let's see what we have here. So a 70-year-old woman is brought to the emergency department by her daughter due to 2 days history of fever, cough, and a day of excessive somnolence. The patient has a history of hypertension and osteoarthritis. She does not use tobacco or alcohol. She lives independently in a senior residential facility and ambulates with the assistance of a key. Temperature is 39.2. Blood pressure is 110. Pulse is 110. Respiration 24. No pharyngeal erythema or cervical lymphadenopathy is present. Lung auscultation reveals crackles in the right lower lung field. Lab results are shown. Leukocyte 13,800, blood urea nitrogen 22, creatinine 1.2. Chest X-ray shows a right lower lobe infiltrate. Which of the following pathogens is the most likely cause of this patient condition?
I'll go with strep pneumo.
Strep pneumo.
Strep pneumo. So strep pneumo. That's the commonest cause. Let's see what we have here. Okay. A 55-year-old man comes to the emergency department due to 2 days history of fever, chills, and productive cough. Over the past 4 months, he had 2 episodes of pneumonia, both of which resolved completely with antibiotics. He smoked a pack of cigarettes per day for 30 years but quit following the second bout of pneumonia. The patient's only other medical problem is hypertension. Temperature is 38.9. Blood pressure is 130. Pulse is 98. Respiration is 18. Oxygen saturation is 94% on room air. Crackles and increased breath sounds are present over the right lower lung field. Leukocyte count is 14,200. Blood urea nitrogen is 12. Chest X-ray reveals right lower lobe consolidation. Antibiotics are administered. On follow-up 5 days later, the patient described improvement in his cough and fever. Crackles are still present in the right lung base. Review of the chest X-ray obtained during the previous episode of the pneumonia reviews, a consolidation in the right lower lung segment. Same as found in the current episode. Which of the following is the most appropriate next step in the management of these patients? Barium swallow, bronchoscopy, CT scan of the chest, repeat X-ray in 6 weeks, serum quantitative hemoglobin assessment.
C.
C, right? Hello?
Yes, it is.
Why? Why are we picking C?
Within this short period, we don't expect the lesion to resolve. Maybe you repeat the X-ray, you continue the treatment and repeat the X-ray in 6 weeks, then the lesion, the consolidation will resolve completely.
No. So this person is
No.
having recurrent pneumonia. We're discussing something and we said if we see somebody having recurrent pneumonia, we should think of
I
something.
think I would like to do bronchoscopy to rule out malignancy because of recurrent
But
pneumonia.
okay, but is that something we can do that is less invasive?
CT scan. That's CT scan.
Yeah, CT scan. CT scan.
Yeah.
But bronchoscopy is a little bit invasive, so CT scan will be more appropriate to do to rule out like a lung cancer because this person is having like recurrent infection on the same site. So that is likely going to be like due to like a bronchial carcinoma obstructing the airway. So you need to do a CT scan to rule out cancer. Okay. So recurrent pneumonia, think about cancer. So I'm going to look for some questions about this antibiotics for pneumonia. Let's just try and solve some of them. It's very important. You know, they can test it. They test it in our UO too. You know, some of those questions. So let's try and solve as many as we can. So moving on to influenza. So influenza, you know, it's highly contagious. You know, there are different types, ABC, you know, and we have subtypes. Influenza A have two subtypes, the H5N1 and the H1N1. You know, this is just combination. We don't really need to worry ourselves about it. So there's something we call the antigenic drift and the antigenic shift. So antigenic shift just means that antigenic drift just means that the virus is changing, is having some point mutation in the gene that is causing some gradual change in surface protein. So if this is the virus here, so there's a point mutation somewhere within the genome that is changing some part of the protein. So if the virus has like 20 protein, you know, surface protein, and maybe 2 has changed. So that has changed the virus in a way. So it means that some people might not be able to stay immune to that new virus. So they can have infection. So even someone that have been infected with influenza before, once the person, you know, once this antigenic drift happens, they can get infected again because the antibodies that they are formed might not be able to, or the T cells or anything that they have formed against that virus might not be able to fight it again. So they might get exposed to it again and get infected. So that is antigenic drift. It's not, there's no severe changes, but antigenic shift, the entire genome is changed. The entire genome is changed. So all the protein entirely, everything is changed. So there's nobody that can be immune to that virus. So that one has a very strong capability to cause pandemic and travel very far and wide. So shift is more severe, SS. Shift is more severe than drift. So shift usually cause, you know, pandemic, and it is due to significant genetic reassortment. So the entire genome is changed, you know, in shift. Why drift is just due to like point mutation in one part of the genome. So in the US, the typical influenza season begins in November and ends in April. So this is the time that they get the vaccine. So it's usually recommended in all patients if they are more than 6 months, and anybody between 6 months to 8 years, they have to take 2 doses of the vaccine. So don't forget chickenpox too. You know, varicella vaccine is 2 doses. MMR vaccine is 2 doses, 1 to 4 years. Same with the varicella, 1 to 4 years, 2 doses. Influenza, 2 doses, between 6 months to 8 years. So anybody more than 65, you also have to give them the vaccine. Very, very important, or if they are immunocompromised, you have to take a very high dose flu vaccine. Somebody with influenza, how are they going to present? You have fever, they can have muscle pain, myalgia, they have chills, they have coryza and weakness. So if you look at this one now, it's kind of atypical. You don't expect myalgia in a normal pneumonia. Now, if you see somebody having myalgia, coryza, think about influenza as a cause of that pneumonia. Very, very important. So how do you test? You can do your rapid influenza test. You can do your rapid influenza test quickly, but the most accurate one is to do your PCR or your viral culture. But overall, it's a clinical diagnosis. You don't need to worry yourself. So leukopenia is a very common thing. Just give supportive treatment. That's all about influenza. Give supportive treatment. And if you pick it within 48 hours of presentation, you can administer oseltamivir, zanamivir, which are like neuraminidase inhibitor. But if it's more than 48 hours, these guys have any little or no role to play again. So within 48 hours, give this guy and provide supportive treatment. So um influenza can cause some complications, and these include ARDS, can cause bacterial pneumonia, superimposed bacterial infection like strep pneumo, staph aureus, Haemophilus influenza. It can cause sinusitis, bronchitis, even exacerbate COPD or asthma. So it can even lead to myocarditis, pericarditis, just name it. So this is a very serious problem for people that are immunosuppressed. They are the ones that can develop ARDS and other things like that. So let's look at aspergillosis. So we already talked about this briefly 2 days ago, and this is just a condition caused by aspergillus organism, and how do we identify aspergillus? Silver stain, branches at less than 45 degrees, and the hyphae are usually septated. So we talked about allergic bronchopulmonary aspergillosis as being typically seen in people with asthma or cystic fibrosis. We talked about the presentation. They can have features of bronchiectasis, hemoptysis, fever, cough, weight loss. You give antibiotics, it doesn't work. If you test for your IgE for aspergillosis, will be present. There will be eosinophilia more than 500. And what you want to do is just to give steroids and what to give. Anybody remembers what to give again? What do we give?
Atraconazole.
Yes, itraconazole and voriconazole, very important. And you manage the asthma. You manage the asthma very well with IgE, anti-IgE like omalizumab, if you want to give that. So aspergilloma is just like seeing like a ball of fungus in a cavity within the lungs. So it usually occurs in people with pre-existing cavitary problem, like from tuberculosis or even from COPD, and they are asymptomatic. It's something you can accidentally like discover from doing the chest imaging. But sometimes it can be bad that they can erode into the surrounding vessel and they can present with hemoptysis. So when you do your imaging, you're just going to see solid mass within a pre-existing lung cavity, and it moves with repositioning. What do you do? So so this is going to be like the presentation. So you see the mass within, the cavity. So ball of fungus within the cavity, that is aspergilloma. So antifungal might not work. You might find it very difficult to penetrate into the cavity. So what you do most of the time, if it's symptomatic, is to go in and do a surgical resection of the lesion. And if the person is having like massive hemoptysis, you might try to embolize. So there's also chronic necrotizing pulmonary aspergillosis, and these people, just like aspergilloma too, they are going to be having like so they can have cavities too, but the cavities is usually from the effect of the aspergillosis, not like in aspergilloma, in which they are just occupying the cavities. No, you are not going to be seeing ball of fungus within the cavities. You are just going to be seeing different cavities, in the lung because of the effect of the aspergillus organism. And it's very common in people that are immunosuppressed. People that are immunosuppressed, people that are on steroids, so they have very weak immunity. So that aspergillus organism is going to be causing necrosis of the tissue with formation of cavities like tuberculosis. So most of the time you might just want to give, voriconazole to treat it, and the patient is going to be all right. So that's all we just do. For invasive pulmonary aspergillosis, they can have cavities. So this one too is very common in people that are immunosuppressed. They can have cavities in the lungs, but the problem does not stay in the lung, because don't forget, the word is invasive. So they are moving outside the lungs, they are going to other tissue sites. So they can go to the brain. They go to the brain, they can have features of meningitis. They go to the skin, we are going to see like different lesions. You can see nodules, erythema, you know, different lesions in the skin. They can go to the joints, they can go to different sites. So most commonly they go they affect the lungs, they affect the brain, they can affect the skin. Invasive. So they're going to tell us that the person is having like some form of immunosuppression. That is the cause of the dissemination. So they can have fever, cough, chest pain, non-specific symptoms. If you do some tests like galactomannan test, it's going to be positive. If they don't put galactomannan test there, they can put uh, beta glucan, test there too. It's also going to be positive in people with aspergillus organism. So you want to give voriconazole, and sometimes you might want to add echinocandin to it. So the only one that you don't typically use antifungal is aspergilloma. So those ones you just offer like surgical resection, Then, okay, let me see. I think I have like a question here. Let's see. Okay, let's just do this question. I will just call it a day. A 54-year-old man comes to the office due to fatigue, productive cough, with blood-tinged sputum, and a 7 kg weight loss over the past few months. He has no fever, chest pain, or night sweat. 10 years ago, the patient emigrated from Vietnam, where he received treatment for pulmonary tuberculosis. He has no other medical history. He does not use tobacco or drugs, but he drinks alcohol occasionally. Temperature is 36.7, blood pressure is 120, pulse is 82, lung auscultation reviews right-sided bronchial and crackles. Creatinine is 1.1 and urine acid is normal. CT scan of the chest is shown. Oh my god, we have the CT scan. Because sometimes you might not save all these things. Okay,